Okay, Assalamualaikum and greetings to everyone from the group A. So,
Waalaikumsalam.
Waalaikumsalam.
Salam.
Waalaikumsalam.
okay, okay, is everyone here?
Yeah.
Yes.
Okay,
Yes.
okay, I think, okay, without further ado, okay, so can I get someone help to present the case?
Me.
Right, okay.
Can.
Okay, but we
Thank
have to wait.
you.
Okay, okay.
Um,
Okay, anyone to say anything first about the case?
First, history, right? Patient history.
Yes.
Yes.
Okay, we start with our patient's history. Okay, first, our patient is female and 18 years old. Okay, it states that from 6 months ago, uh, from 6 months ago,
6 months ago.
he had an accident.
Accident.
Okay, so for the accident, the patient has corneal scleral laceration on the right eye with iris fluorescence. So,
So that.
what is corneal scleral laceration?
Cornea?
Corneal scleral laceration. From the incident, the patient has corneal scleral laceration and iris prolapse. So, the corneal scleral laceration is when it happen when there is a severe blunt trauma or any penetrating injury. So if there is any penetrating happen to our eye, so that's called as corneal scleral laceration. It
Penetration.
happen
Oh,
on the right
penetration.
eye only.
Oh.
Yes. It also may be due to any inflammation or infections actually. So I think for by this accident, I think it caused by the blunt trauma lah, or the penetrating injuries.
Oh, yes.
Yes. Okay.
From the accident.
Uh-uh.
Oh,
Yes.
okay. Okay. Understand.
So, for iris prolapse, which is this iris prolapse is occur when the iris tissue, which is on the right eye, is observed outside of the wound, which is this made due to the high pressure behind the iris and low pressure in front of it, which is so this pressure will gradient, which is they will move the iris from the high pressure into the low pressure. So this pressure is maybe due to the accident that caused the pressure inside of the eyes become increased. Alright. So next, which is okay. So for the next day, laceration repair with residual ocular ST and infrared iridectomy. So okay.
Good. I read it from you.
So Amira, do you know what is laceration repair?
So basically, laceration repair when the surgery is repairing for the corneal scleral laceration actually. So that's what the surgery aims for. The surgery aims to restore and to maintain any integrity of the globe. So then it can avoid any further intraocular damage. And it also can prevent for any permanent corneal scarring and astigmatism. That's why we need to do the laceration. So that's why there is history about the laceration repair in the history record.
Oh, okay.
Then
Section.
any other question? Alright. Inferior iridectomy also, we want to reduce the ocular pressure inside the eye. So because of that, the surgery also done. So next, for the 1 month later, the patient is diagnosed with traumatic cataract and zonula dehiscence, I think.
Dehiscence, yes, okay.
So,
Okay.
What is that?
Zonula dehiscence is actually is a rupture of the fibrous stand connecting to the ciliary body, which is inside the eyes, and also the crystalline lens, which is it's also can is happen due to the accident. Okay, for the traumatic cataract is this cataract has also happened due to the trauma or injury like the patient accident. I want to add for the residual ocular astigmatism, which is residual ocular astigmatism, which is ORA, is basically is the astig, which is not due to the optical, which is it happened due to the inside of the eyes, which is the inferior of the cornea and also um the inside posterior of the lens.
Posterior.
so that's why we call it as residual.
Yes.
Good.
Okay.
Oh, now I
So,
know.
for the next one, 2.5, 2.5 months lah. 2.5 months later, the patient undergo some surgery, which is posterior vitrectomy, laser photocoagulation, and the sutured spherical IOL implanted. This surgery is to correct for the diagnosed one, the 1 month later one, the traumatic cataract and the zonular dehiscence. So for the posterior vitrectomy also, we'll remove the eye cavity to have a better access to the retina during the surgery lah. So it can repairs and remove any scar tissues during the posterior vitrectomy. And after that, after it remove the eye cavity from the eyes, then there is like nothing in the eyes, right? So now they will injected a gas bubble into
What
the
bubble?
area.
Yes,
The gas
but
bubble, just gas bubble.
Gas
So
bubble.
that
Okay.
after the surgery is done, then some vitreous will create automatically like normal. So that gas bubble will like disappear just like that. So that there is no fragments like if when we know the accident happened, it may cause some pieces of fragments from the eyes into the vitreous, right? So we use this surgery to make sure that any fragments from the eyes at the vitreous humor can be eliminated. It can be out from the eye. Because of that, we have all this surgery.
Understand?
Mm-mm.
Understand.
okay.
So, patient come to the clinic because she want to look for something to improve her vision at distance. So basically, all the surgery happen. That's already corrected, right? So, the
Yes.
only chief complaint here is she just want to improve her vision at
Vision.
distance.
Vision.
Hi.
Is it all?
Wait.
Okay. Okay, you can ask any question if you have, or if you
Okay.
know.
For iris prolapse, I think. Okay. So it's actually have they have management for two, which is in no, which is laceration repair, which is actually they have a small they have small and um also large, which is this case we show the larger wound with gap that should be surgically repaired at the primary closure or by graft grafting. So if this iris prolapse is caused by the acute, which is actually we can use only the eye drop, like yes, eye drop. Okay. So that's all.
Okay, is it all? No question left, right?
Um, I think that's all.
Okay,
I think.
I think we can move on to the next aspect of the case. So I think it's about the below one, the table one is about the clinical finding. So okay, anyone anything to say about the clinical finding?
Yeah, I got some points to say about the clinical finding. So as we can see from the VAI, we can see that the left eye is considered normal, which is 4.5,
Left
and
eye,
then
yes.
we can see the right eye has some problems, which is it has the VA of 6/60, and its pinhole it just improved until
Improve.
6/15,
Mm,
and yeah, it improved, but does not reach 6/6.
yes.
Yes.
So it shows that the patient has something wrong with either pathological or other things. Next, for the subjective reflection, as we can see, the left eye is plano as expected
Mm-mm.
because the habitual VA is already good. But on the right eye, we can see that the patient has the power of plus 0.75 and the astigmatism power of minus 1.5 diopter cylinder with the axis of 35. So here we can see that the axis is 35, which is oblique astigmatism. Am I right?
Okay.
Yeah.
Oblique.
So the other thing is if we compare the right eye and the left eye, on the astigmatism power, we can see that the left eye has no astigmatic power, but the right eye is minus 5.5. So it is considered anisometropia. Am I right?
Yes. Nice. So,
Yes,
Yes.
and then
So
so
Yes. Oh, that's it, right?
yes.
and then so difference how
To
The
many?
that.
the the,
Oh,
the
Yes.
difference of power is more than 2 diopter.
oh. Hmm.
Okay.
And then for the lids and the lashes, you can see there are no problem on both eyes.
Mm-mm.
But on the conjunctiva and sclera, we can see that on the right eye, which is the eye that the patient have been injured before. So we can observe that there are two sutures above the limbus and also two sutures inferior to the limbus. So these sutures actually can also contribute to the astigmatism power because the sutures can cause irregular surface of the
Okay.
cornea.
regular surface.
Eh,
Yes.
oh, irregular what? Sorry.
So fit.
Irregular surface.
Irregular cornea surface.
Oh.
Yes.
Oh. Okay, I see. Okay.
So are you guys clear about those points?
Yes.
Yeah.
Yes. Very clear.
So may I
Not that
proceed?
teacher.
Okay. Yes now.
Hello?
Yes.
So may I proceed for clinical finding on cornea?
Okay. You may.
Yes.
Okay.
Yes.
So for clinical finding on cornea, this patient has neovascularization at the upper limbus of cornea in the right eye that we found through a slit lamp. Normal cornea has no blood vessel. The corneal neovascularization is a typically secondary to one of two types of condition, either inflammation or hypoxia. So on the left eye, the cornea is clear. Yes, Nurin, do you have question?
No, I can't hear you clearly. I don't know. What is that sound? Okay.
It's
Okay.
something interrupt.
Oh, okay. Okay. No sound right now.
Mm.
Do you guys hear me well?
Yes.
Yes.
Yes,
Now
Alia.
you sound clear. Yeah.
Yes. Now clear.
Oh.
But earlier that I have explained, do you guys hear?
Yes.
Not really.
About the
Yeah.
Not
vascularization.
really.
You catch.
Yeah.
I think I need to rewind.
Yes.
Yes.
Yes, you
If
can
you can repeat.
try to repeat.
Can I?
Yeah.
Can.
Okay.
You may start now.
For clinical finding on cornea, this patient has neovascularization at the upper limbus of cornea in the right eye that we found through a slit lamp. Okay. So, normal cornea has no blood vessel.
Yeah.
Good.
True.
Therefore,
Transparent.
yeah.
Vascular.
Transparency.
So, this cornea neovascularization is typically secondary to one of two types of condition, either inflammation or hypoxia.
Ah.
So,
For this case,
Yeah.
on the left eye, the cornea is clear. You guys have question regarding neovascularization?
No.
No for me.
No.
But I think, I think I want to add, okay, I think the corneal neovascularization is caused by inflammation.
Oh, for this patient? You mean for this
Uh,
patient?
yes, for this
Oh.
patient.
Oh, okay.
inflammation because of
Accident.
Inflammatory neovascularization is commonly caused by traumatic injury, bacterial and viral infection, or chemical burns. So for this patient case, she had an accident and had corneal scleral laceration on her right eye that occurred following blind, penetrating, or perforating ocular trauma, as Amira said, right?
trauma.
Yes.
Yes.
Oh, so the trauma caused the inflammation and that's why new vascularization
Neovascular.
occur. Oh, okay. Understand.
Okay, next, iris. Right eye iris is not normal in shape. You can see that. It is it is supposed to be in circular shape, but this patient iris give a keyhole or cat eye appearance.
Oh,
The
Alia,
pupil. The
Yes.
pupil.
can I know how can the iris become like that?
It can be genetic or traumatic, but in this case, it may result from the accident. She was involved 6 months ago when her iris ruptured.
Oh,
Yes, iris.
yes.
Correct.
Makes sense.
Yes, but her iris on left eye is normal with circular shape.
Yeah.
Oh,
Okay, next, the anterior chamber. The anterior chamber is normal, deep and quiet for both eyes.
Okay.
Normal.
Normal.
No problem.
Yes. Then we move on to the lens. Okay, on her right eye, there is insertion of an intraocular lens to treat the traumatic cataract. So, and her lens on left eye is clear and transparent.
Why not it scroll down?
Why not?
Sorry.
Okay.
Oh, okay. It's okay. It's
Okay.
alright.
For the lens,
Ulang ke? Ya. Okay, next is the lens. Okay, on her right eye, there is insertion of an intraocular lens to treat the traumatic cataract. So, and on her lens, on left eye is clear and transparent.
Nice.
oh, so we can see the IOL in the right eye,
Yes.
right? That is the IOL, right?
Yes.
Yes,
IOL.
they treat the traumatic cataract.
Oh.
Okay.
Traumatic. Oh, the
Okay.
IOL. I
Okay.
see.
Okay. By the way, guys, okay, for the next observation, what do you can understand from the patient corneal topography finding? Is it the
Um,
topo normal?
wait, my D.
I can't hear your voice clearly.
Okay.
Um,
I just ask you guys, is there any significant finding from the corneal topography findings? So the testing is normal.
I have to say about corneal topography. Can you guys hear me?
Yes,
Yeah.
Akila. Yes.
Yeah. Okay. From what I can see here, it stated that the power of the patient's eye is 44.4 diopter in the right eye, and for left eye is 44.1 diopter. And this power is absolutely normal because the normal value of corneal power is around 40 diopter to 46 diopter. And
Mm.
for the power part,
Oh, okay. Akila,
yes,
what about the value below the power? I mean the one in millimeter. What does the value indicate?
is it the one with for 7.0 millimeter and for left eye 7.65 millimeter? Is that
Oh
the
yes,
one you're
that one.
saying?
Yes,
Okay.
that's the one.
Okay, for
Can
that
you
value,
explain?
okay. That value that value indicates the radial curvature of the center of the cornea. So the normal
Mm-hmm.
cornea has an average radius curvature approximately around 7.83 millimeter with
Mm-hmm.
plus minus 0.19 millimeter. And
Mm-hmm.
there you can see that the patient's radius of curvature is 7.60 millimeter in the right eye, and for left
Mm-hmm.
7.65 millimeter. When we compare it to the average normal value, so we can it is safe to say that this patient has normal corneal curvature as the value is within the normal range.
Oh,
Mm.
Okay, okay,
Mm.
okay.
I see.
How about the SIMK value? Is there any of you know what does the SIMK value?
Me, I think I know what is MK value.
What is it?
Mm.
Can you explain?
Okay. Um, SIMK is the short form of simulated keratometry. Okay. So this measurement actually characterize corneal curvature in the central part of cornea around 3 millimeter area. Okay. So if you find the difference or minus the flattest value with the steepest value, the flattest SIMK value with the steepest SIMK value, then you will get the amount of corneal astig in that particular eye.
Oh,
That,
flattest minus steepest.
yes, yes, flattest minus
Okay.
steepest. Ah,
Oh,
so
true.
now I just realized that the amount is nearly the same.
alright.
Mm.
Okay. So what about the fashion Cynthia Living? Can you explain a little bit more, a little bit detail about that?
Oh, okay. Okay, as you can see there, in the right eye, okay, I'll give you example in the right eye. Okay, the flattest value, which is the blue color, for your information, the blue color indicates flattest value, while the red color indicates steep value.
Steepest.
Okay.
Okay.
From the patient finding, the flattest value is 41.87 diopter, right?
Yeah.
While the steepest value is 46.87, the one in red. So
Mm-mm.
if you minus both value, the amount of corneal astig will be minus four minus five. Sorry, minus five.
Yes. Minus
Okay.
five.
Okay.
Ah,
Okay.
Okay, Wawa, can you scroll up? Scroll up. The subjective refraction. Okay. Okay,
Okay.
if you compare the amount of corneal acid from the same K value, when you minus, you will get around this nearly the same acid amount compared to the subjective RX.
Oh,
Understand?
Okay.
so it's almost the same.
Yes.
Oh,
So
okay.
Okay.
that's
Okay, so regarding the topography finding, okay, you guys notice that that there is some blank space in the corneal topography of the patient right eye.
Yes.
Yes.
yeah.
Yes. It's
Serious.
But
quite right.
but honestly, I don't know why the topography look like that because it's kind of look unusual compared to other normal topography, right?
Yeah, but I think maybe the reason is about the neovascularization just now.
Yes.
Okay.
New bus.
Can you justify your opinion, my D?
Okay, what can I scroll
What?
scroll up
Uh-uh.
on the cornea image.
Neobus.
This.
Okay,
This one.
okay, so the cornea image. So if you guys look at the slit line finding, the cornea specifically, it shows that this patient has a neovascularization at the upper limbus of the cornea. So this might be the reason why the patient corneal topography has some blank space at the superior part.
Oh, I
Okay, I
see.
see.
Oh.
Okay, then
Oh.
I,
Okay.
I have question. How about the overall shape of the cornea? Does it can be considered as either regular or irregular astigmatism, Maidi?
Okay, so for that, firstly, if we look at the difference between the two meridians in both the eye, it is 90 degree to each other, right?
Yes.
Yeah,
It
yeah.
degrees to each other. But we also have to consider the overall shape of the cornea itself. So normally the regular astigmatism has a steep surface at the center and become progressively flatter at the peripheral. So based on the right eye, we can see that there is an even pattern of symmetrical bowtie. So
Yes.
okay. So
Okay, okay,
therefore, we
okay.
can say that the patient has irregular astigmatism on the right eye, left eye.
Oh. But Maidi, why do you think the patient has irregular astig only on her right eye?
Right eye.
So for that,
What
I
is
think we can have a look at the patient history because the patient already stated that he had a trauma 6 months ago that caused a corneal scleral laceration.
Oh, yes. Oh, yes. Okay.
Because of cornea sclera.
Restoration.
Corneal
Oh,
scleral laceration.
Okay,
Oh, I
oh,
okay.
I
understand.
Oh, because the cornea scleral laceration is only on the right eye. Okay. Okay.
Yes.
Okay. It makes sense now. Okay.
Yep.
Thank you, thank you.
Okay.
I think the only left question is the management, right?
Yes.
Yes.
Okay, so
I want to add
We
something.
have not done the diagnosis.
Yes,
Diagnosis.
Diagnosis.
Oh,
We left the
diagnosis.
diagnosis. We
diagnosis.
don't
yes.
have any diagnosis from the ear.
Good.
Fitri, what do you want to add, Fitri?
Isn't it
No, I just want to remind that we have
Just
not covered yet
uh,
the diagnosis.
Let's start from the first one.
Oh, diagnosis.
diagnosis.
Okay.
Okay. Okay, I'll take the part diagnosis, okay?
Okay.
Sure,
Hmm.
sure.
Okay, in my opinion, I can diagnose that this patient has the first one is iris coloboma. which
coloboma.
is yes, this part. Iris coloboma is due to the effect of the iris prolapse.
Yes.
Oh,
Yes.
Iris coloboma means that I found from the research, it stated that iris defect or whole defect of the iris at the part of anterior, any defect in the iris that allows light to enter the eye or other pupil is called coloboma. So that is because iris coloboma induce photophobia. We can see here that the patient has very high amount of ST, right?
Estate,
yes.
yes.
So of course, this patient has very sensitive to the light. Mm-mm. So yes, anyone want to add
Maybe
another diagnosis?
maybe I can add up for diagnosis of pseudoaphakia. What do you guys think? Because this patient, if you can see at the slit lamp examination, you can see that this patient do have IOL implantation, right? So we can say that
Yes, I yes.
he is diagnosed with pseudoaphakia lah.
So she is pseudoaphakic patient, right?
Yes.
Yeah,
Yes,
but
that's
only
all.
at the right eye lah.
No, for the
Because-
right eye.
Okay.
Because the left eye is normal, so it only applies on the right eye. Okay.
Okay, for the next diagnosis, I think this patient is anisometropia, which is, as we can see from the subjective refraction, this patient have very significant difference between right eye and left eye. So, okay, because the normal difference between right and left is not more than 2, right? So this patient already exceed, which is especially the amount of ST. The left eye has no ST, whereas the right eye has very, very high of ST. And plus the VA is not improved.
So I think
Yes,
they
maybe
may
that.
have the strabismus
And also,
lumpia, right?
Yes, because the
In
VA is not improved.
yes, which is the power on the right eye is too high, which is they may have the deviation on the right eye. I think.
Oh, I agree with Isa.
Maybe.
So, Prince, what do you think? Another diagnosis for this patient?
Oh yeah, before sorry, I apa terkeluar. I have connection just now. But if I can add before I forget that this patient do have problems on the right eye regarding the subjective refraction RX. You can see that this patient have plus 0.75 sphere power and negative 5.5 cylindrical power. So I can say that yes, she is diagnosed with irregular astig on the right eye. But just like what Maidi have said, due to some problems, yeah, this patient, in my opinion, I think we can confirm that this patient do have diagnosed with irregular astig on the right eye.
Me too, I agree.
Regular
Yeah.
astig.
Yes.
Okay, so the last one is the trauma, right? The patient has trauma that induce the corneal vascularization.
Neovascularization.
I think that's the first one is iris coloboma, and the second one is pseudoaphakic. The third one is anisometropia with amblyopia on right eye, right? And then she has irregular ASIC along with the corneal vascularization.
So we have
I want to share something. For the iridectomy, which is from the history, which is this is used to sorry lupa. Yeah, is used to treat usually to treat the glaucoma patient, which is the IOP is increased. So from the current visit, we can see that there is improvement on the IOP, which is from the can you move down?
Which part?
For move down. Okay, for the anterior chamber. Alright. So which is deep and quiet.
Deep and
Which is
quiet.
deep. Yeah, so it means that the IOP which is improved, which is there is no symptom of glaucoma.
This is all because of the iridectomy.
Yes. From my reading.
Iridectomy.
Iridectomy. Superior iridectomy.
So the only traces from the accident is the iris coloboma, right? The iris coloboma, the IOL.
Yes.
Okay.
I think that's all for the diagnosis. Is anyone of you want to add more? Some more?
No.
I agree with your suggestion.
Yes.
With your
So let's
ideas.
move on to management. What do you guys think?
Good.
So for can you guys hear me?
Yes.
Yes.
Can I start now?
Yes.
Can
Management.
for the management of this patient, so in my opinion, like from the diagnosis that has been stated just now, which is first the patient is diagnosed with iris coloboma, isn't it? So the management, it should be something that can mask the disfigured appearance of the patient's iris, but still it should be functional to the patient. For me, from the aspect of the optometric care, for iris coloboma condition, supposedly we should prescribe patient with prosthetic contact lens.
Oh,
Prosthetic.
Contact lens.
We have learned about that before.
Yes.
Yes.
Nina,
Yes.
can I ask?
Okay.
How the presence of iris coloboma can affect this patient beside photophobia?
So the presence of iris coloboma, like Wawa has mentioned earlier, which is it can lead to photophobia first. Second one, which is it could lead to greater chromatic and spherical aberrations, and also poor cosmesis. Cosmesis is a cosmetic appearance to the patient. So am I answering your question, Fatih?
Yes. Thank you, Nina.
All right,
Okay.
welcome. Okay, so back to this case. So the usage of the prosthetic contact lens, it can be used to alleviate all the symptoms mentioned earlier. So other than that, patients also diagnosed with corneal neovascularization, right? So which it is the invasion of the blood vessels into the cornea from the limbus. So I think that we should take this into account, into consideration, what material and characteristics of the prosthetic contact lens that we will prescribe to this patient, since the patients have already corneal neovascularization. So basically, it should be the contact lens should have the high oxygen transmissibility. For example, like the materials of silicone hydrogel lenses, and also it should have a low water content. So
Hydrogen.
yes, so from my reading, it stated that actually the contact lens that have the high water contents, actually it will loses the moisture to the environment. So it will be absorb more water from tears and potentially can decreasing the moisture on the cornea. So actually it will make the cornea neovascular of the patients become much worsened. So took into this consideration is not only prevent the other formation of neovasc on the patient's cornea, but it also can control the neovasc of these patients that already have. So that is actually my management for these two diagnosis that has been made earlier. Um, so how about you, Amira? What do you think the other management for these patients regarding on her diagnosis?
Okay, for short-term management, in my opinion, for irregular astig and anisometropia, I think um, we should prescribe her with partial power of astigmatism spectacle while maintaining spherical equivalent, which is for right eye plus 0.75 diopter sphere minus 1 diopter seal at 35 degree. And for left eye, plano. Actually, there are reasons why I prescribe partial spectacles for this patient. This is because
Why?
she is a first time wearer. So it is better to undercorrect seal power to make sure that she can adjust it easily.
Chicken?
Cylindrical power will be increased on the next visit until full cylindrical power is prescribed. Besides, actually we can also prescribe this patient with RGB contact lens to manage high irregular astig. But I think because the patient also have iris coloboma, it is better to only prescribe spectacles because this for cosmetic appearance, prosthetic contact lens is better for her to cover her iris coloboma. Apart from that, um, spectacle frame should be sturdy design with lightweight to prevent pressure on the patient's ears. The lens design should also be durable. I will suggest lens such as CR39 and polycarbonate because of their lightweight and durable.
Yes.
I think we can also add the AR coating for
Yes.
For the
if
spectacle.
the
Right,
aesthetic is
Iza.
high.
Good idea, Iza.
Good
We
idea.
are
Yes.
Ah,
Okay,
So,
aku
I want to ask between the contact lens and the prescription spectacles, which one did we use for the management?
We use
We use
both.
both.
Yeah.
Yes. From what I have mentioned earlier, the contact lens is used as only to cover the disfigured appearance of
Oh,
iris
so there is
glaucoma.
no prescription
Yes,
in the contact
it
lens.
just
Oh,
plain,
I see.
but still, but still we need to prescribe it, right? We use the word of prescribe for the patient. It's
Okay.
like
I
mm,
understand.
so contact lens with spectacle. Oh.
yeah,
Ah,
contact
Get
spectacle.
together. We use it as together, I think.
Yes.
Or
Okay,
like
I
the prescribed patient.
see. Oh, well done, Nina, Mira. The great management
Good.
on tackling the problem. But I think just now you guys just say about short-term
Short term,
management,
right?
right? So I think we miss out the long-term management.
long term.
How about the long
Can you
term?
guys share about the long-term
Okay.
management?
I think I have some idea for the long term. May I?
Oh,
May I
yes,
say?
Yes,
Sure,
Fatin.
sure.
okay, of course, of course. I'm waiting for you.
Okay, so for my opinion, for the first opinion, I would like to suggest like with to the passion to come again for the is for jap.
Cepat, cepat.
Sorry. Okay. Okay, for the first appointment, I would like to suggest to come this patient to come again in 2 weeks after prescribing the new RX. Okay. So in this first appointment, we can monitor the patient vision and visual performance with this new RX. Okay. Since as we know that as the this patient have a high astigmatism power, right? So we must check whether this patient already adapted with the new RX. So this is why we prescribing the partial power for the astigmatism.
Okay. I
I
see.
support the suggestion, Fatin.
Yeah, yes. That's why we
Yeah.
start only the partial power only.
So,
Okay.
since we use the partial power, how about the next follow-up, which is about the period of time that we should take?
So as we learn in the class, actually the lecturer did mention that if we prescribing a partial power to the patients, we must at least one increase the power in 6 months period. Right?
Oh, 6 months.
Yeah.
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 At least. It's not like
At least 6 months.
So I have a question. So if you want to prescribe for the partial, so here the astig is minus 5.5, right? So for the partial, how much amount of astig will you prescribe for?
At
For the
first, we
partial,
will prescribe -1.
minus 1.
Oh.
Yes.
Yes.
With the
And we will
RGB,
increase. Oh no,
Doesn't
no
it
RGP.
With the
you
spectacle.
use soft contact lens. Means.
contact lens.
No,
This is
so
for the
lens only for
spectacles.
purpose.
Okay, okay.
The
So
one that
Amira,
power is the
Sorry.
spectacle.
Amira said we give -1 astig.
Yes. Yes.
I think it's just like too low, right? It's too low.
Maybe
I think we
we
can
can
start with
add like 2.5, like
-2.5.
maybe half.
Yes, I agree with that.
Yeah.
We can
Minus
start with
2.5.
-2.5
Yeah.
because it's
For
like a
for
long
the
journey if we want to start with -1 because the
oh
fully astig is -5.5.
for
Yeah,
the
yeah.
I agree. I agree.
But only if the patient cannot adapt, then we should use to decrease the estate maybe.
We need
Yes.
to do the
We
trial
need to
period
consider,
first.
yes, consider the patient compliance.
Right.
Yes, that's right.
Exactly. So, I think for as we already just say just now for the partial power, so the next follow up, we need maybe I would like to suggest like about 3 months after that, the patient comes again to check whether the patient is already adapt with the new prescription, because after that we have to, like as Nina said just now, we have to at least increase the power in 6 months, right, Nina? Right. So with that, we can increase the C power every appointment if the patient adapt with previous power. So thus we can schedule the next appointment with the same time frame until the full C power is prescribed. Like just now we give one -2.5. Maybe in the next appointment we can give like increase like 3 or 3.25, like that. Yeah.
Yes.
And beside we can also like just now we diagnose with what we call neovascularization and pseudo affected, right? With
Yes.
along the appointment we can also like see the progress with this diagnosis, so we can see lah, is it the disease getting better or is it getting worse?
Do we give any treatment for the neovascularization?
This neurovascularization we tackle this problem together with the what we call the iris coloboma, which is we have the low waterability, if I'm not mistaken, Nina said just now.
Oh yeah.
Yeah.
To avoid the new vas become much worsen when we prescribe the contact lens. But I think like Mira asked just now, I think I just read that to treat this new vas outside from the optometric guide, it also could be like, I think surgery or LASIK. I'm not sure between these two. Did you guys know?
I think that
between,
no, before
let's say,
before the
surgery.
surgery, we have another
Yes.
treatment actually for the neurovascularization. We can give
Oh,
medication.
Oh,
Medication, right?
medication.
Yes,
Oh,
voice
medication.
medication for the neurovascularization. If anyone of you have read, if I think there is some medication for the neurovascularization.
Oh,
We need
I
to get the
read
medication first and then surgery. Surgery is the second method, is the second option lah.
Mm,
Option.
option.
okay.
yeah.
Also, the first option is medication. Okay.
Medication.
Yes,
Yeah.
like
Basically,
anti-inflammatory drugs.
For yes.
the medication how
Steroid.
only like steroid
I think
drugs.
Yes,
steroid.
steroid.
Uh,
Oh,
I have a
We give
question.
the topical treatment.
Is the medication suitable for both inflammation and hypoxia?
both types of neovas,
Ah.
right?
Uh-uh.
Okay, okay.
Oh, okay,
If it's
understand.
suitable, then okay.
Oh, okay.
So for the medication, actually, we cannot prescribe medication for patient, right? So I
Yeah,
think we can
We
make
can
a
refer
referral
this to
letter.
yeah,
yeah.
you can
to
refer it.
the
Yes,
doctor.
refer later.
Oh.
To the ophthalmic.
Because those medication optometrists cannot prescribe that. Only
Yes.
Yeah,
ophthalmologists.
exactly.
Yeah, that's right.
Okay, I see. I see. Okay.
Oh,
Why
is
Nuri?
there any, is there any management?
No.
No,
I
okay.
think that's all.
I think we have covered all part.
Yeah.
Yeah, that's
I
right.
Oh,
think
Yay!
we finished our discussion for this case study.
Yes.
Yes.
okay. I think okay. If everyone have no more question or any more problems, so I think okay. I would like to congratulate all of you for the cooperation given during the discussion. Okay.
Um,
And also thank you for participation.
thank you. Thank you, Madi, for being our moderator.
Right.
Yeah.
To
Thank you,
our
my dear.
viewers.
Thank you all.
Thank you, everyone. Thank you,
Thank you
everyone. The
everyone,
ideas.
especially my D.
Very
Thank you.
important.